Hi everyone, this is Neil Wright here, consultant, audiologist and director of ClearWax. Thank you for joining me in my latest video using the iClearScope endoscope. This is of a very interesting case of a patient who actually attended today. I'll provide you with their case history. A couple of years ago, whilst on holiday, they developed a swimmer's ear in their left ear. And when they returned, they saw their GP, was prescribed some antibiotics. The infection, the patient felt, never truly went away, and about a year ago they developed another infection in their left ear, and on that occasion they also experienced severe otalgia, so ear pain, which was radiating across the left side of their face and jaw. They went back to the GP, prescribed some antibiotics, but was also advised that they have some earwax. So they went to see a local specialist who advised that they don't have any earwax. So they went back to the GP, and as well as the otalgia and hearing loss, this patient has been suffering from occlusion. So occlusion is when you can hear sounds inside of your head. For example, if you're chewing or having some crisps or biting on a biscuit, those crunchy sounds are trapped inside your head. Your breathing as well, for example, and also autophony, where your own voice is inside your head. They also developed a clicking noise in the ear, but this was triggered when they applied some pressure to the side of their neck. And these symptoms were ever present since their original ear infection 2 years previously. So at that stage, they decided to see an ENT consultant local to them. So this patient travelled quite a distance to see myself, and the ENT, on 2 or 3 occasions, this patient had to revisit. There was some wax on the eardrum, so the ENT removed the wax, and then the ENT did a really thorough assessment of the patient's eustachian tube, checking either whether it's obstructed or if it's patulous, it's permanently open. They also evaluated for tensor tympani disorder. So there's a tendon that's attached to the malleus, the hammer bone. The tensor tympani is also a stapedial muscle in the middle ear, which in response to loud sounds, this tendon and muscle contracts. When it contracts, it stiffens the 3 bones in the middle ear. So the ossicular chain. So the ossicles are the hammer bone, the anvil and stirrup, otherwise known as the malleus, incus and stapes. And when the ossicles are fixed, it tenses the eardrum, so it helps to reflect loud sounds. So it's a reflex, and it's designed to protect our ears from loud sounds. However, in some patients, they can experience random spasming of either the tensor tympani or the stapedial muscle, which can cause a clicking or fluttering sensation in the ear. Nothing was really found other than this patient had some acid reflux, and that has caused some swelling at the back of the throat and nasopharynx. So there's a possible obstruction of the eustachian tube intermittently, because the patient's symptoms were intermittent. And the eustachian tube, which is the pressure equalizing tube in the ear, it connects the middle ear, so the cavity behind the eardrum, to the back of the nose and the nasopharynx. So this patient's been on steaming therapies, and they were discharged, I think, a few months ago. But the symptoms haven't really improved. So the patient came across myself on YouTube. He actually said it was good insight when you have an issue. I mean, I do that myself. If you've got some sort of question or something you're not sure about, nowadays, obviously a lot of people go on YouTube, and this patient came across my channel, found me, I found my content useful, so decided to book in. And prior to booking and reading the notes, I just wasn't sure what I could do for the patient, because they've seen ENT already. So upon attending, they had occlusion, and also their autophony, which is really good. So sometimes patients come and their symptoms are no longer there. It's a sod's law, and this patient's symptoms are intermittents, but today he said they were really bad, which is in a way for me a good thing because I can fully evaluate. So upon attending, hum testing was lateralized to the left ear, which kind of proves the occlusion effect. Weber, which is a tuning fork test, was also lateralized to the worst left ear, which suggests that they've got a blockage in either the ear canal or the middle ear in their left side. So I looked in the ear and they had otitis externa. They had this dead infected skin lining the medial aspect of the ear canal. It was very adhesive, so it was quite sticky. I initially used microsuction, but I had to then use the Correct to glide and elevate that. I then went with the forceps, but I managed to peel some of it away with the forceps, but not all of it. Now they've still got some skin lining the bony part of the ear canal. It's a wafer thin layer of skin, but I will remove that, so do stay tuned. And they've got you won't see it at the moment, and it's as well as this otter ear, this thick creamy discharge on the eardrum, they've got 2 layers of dead skin there, which I'm going to peel away. And when I removed that, instantly, this patient could hear significantly better, and their occlusion and autophony also alleviated. I say autophony, but some people pronounce it autophony as well. It's when you hear your own voice inside your head. I'm not the very best at pronouncing certain things, as some of you may be aware. This was really, really tricky because I went on the eardrum, and sometimes when you apply some pressure on the drum, some of the dead skin comes away, but it was just too mushy. It wasn't coming away. And the patient could hear a lot better already, but I just knew I had to get this out for them. Now, I think this is a fungal, so refer them to their GP and ask for swab to be taken prior to any antibacterials, antifungals being prescribed. This patient does get water in their ears, so I re-instructed them on that. But yeah, after I peeled all this, their symptoms significantly improved. They were still getting the clicking noise though. So, but other than that, they actually felt they could hear better in their left ear compared to the right, which is their better ear. And I explained that because this ear has been blocked for so long, when you can suddenly hear from one ear again, the brain is more attentive to that ear, and it just has to get used to hearing from that ear again before both ears re-equilibrate and the brain gets used to hearing from both sides. So yeah, advise them not to use water, and if their clicking sound is still occurring, they're going to have to see ENT again, but we shall see once this infection resolves. They also have some temporomandibular jaw dysfunction as well, so their jaw joint, it's quite tender, so it's causing a bit of referred altalgia, so referred pain around that region. So whilst you're watching this, I just want to update you on a few things. Now, guys, if you're watching on YouTube, I apologise. I just haven't uploaded recently. I have actually uploaded some videos there, but I haven't published them. And I was just thinking, why I've gone to the trouble of uploading it. Why haven't I published it? And I just realised that with YouTube, and it's going to sound really silly because some of you guys might think it doesn't take long, but it's just, creating new titles and thumbnails. On other platforms, you just upload the video, and I realise that's what's calling me back. It's just I just sometimes just don't have time, and creating the video and then a thumbnail, and then always coming up with new kind of names for videos to make them sound interesting. So what I've decided to do, and I hope everyone who watches on YouTube doesn't mind, it probably means I'll get less views and less recommendations from YouTube, but I'd rather that than not upload. But I'm just going to now upload the video. Use one of the pre-generated YouTube thumbnails, which are not always great, and just label the episode number followed by earwax removal, even if it's not earwax removal. Just in the short term, it's just so busy at the moment, and then when you're uploading on all different platforms, right now it's 7:30 in the evening. I'm still here, but I just wanted to upload this because I know I haven't uploaded in a while, especially with the endoscope. And when I've got a bit more time, it's just so much going on with work, and especially with Clearwax, because there's some new regulatory requirements that I need to get sorted in the next few weeks. And we've been really busy with our new products as well. So just bear with us if you can. Also, something else to share with you guys. I got contacted today by the manager of I've never heard of the show before, but I think it's an American show. They're predominantly on Facebook. They want to do a live Facebook chat with the presenter talking about ear health and well-being. So I've replied back, said, yeah, it sounds good. Depending upon time and, scheduling, I'll be open to discuss that further. But I don't think I can say the name yet, but it's a very popular show. I've never heard of it myself, but they've got 1 million subscribers on Facebook alone. So I'll do some more research on the channel later. So I'll keep you updated on that. So there's still, believe it or not, another layer of skin here on the eardrum. But I'm going to, in a moment, approach it from the posterior canal wall. So I'll just come out. Will I go now, or will I? I'm just going to go back in and I just think I re-angled my fine end, so we can sort of angled it in such a way so the tip is going away from the posterior canal wall, because you can see I'm going to the canal wall and I want to come inward so we don't graze the canal. Some of you must be thinking right now, what is he doing? There's nothing there, but just wait and see what we remove. And this last layer made a big difference. You see it's starting to peel away. And this is coating the majority of the eardrum. So this patient's eardrum was like an onion. It had so many layers of unshed dead skin. I'm pretty sure this is fungal in nature. There's no obvious spores or hyphae, so it's unlikely to be of an Aspergillus strain, so I think it's more Candida. There is a bit of erythemus or redness of the overall ear canal. I've had a couple of fungal infections today as well. In fact, a lot of my procedures now, just talking to my clinic manager, because they are getting more and more complex. I mean, they've been complex for a while, but it's just seeing so many more referred cases from other specialists and loads of ear infections. So yeah, that was an interesting case. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.